focus on trauma in the rural setting, because it sounds like the majority of people are either from a rural center or they're receiving patients from a rural center. And I'm going to focus on basically the realm that I know. As Abby said, I have quite a few years of experience in smaller hospitals, so I do get some of the challenges that rural hospitals face in terms of transport and treatment. And then I'm going to hand off this lecture to Dan to really focus on the EMS aspect of this, transport, what resources they have available for these patients when we send them to another facility. So I'm going to go ahead and start with the recognition of sepsis. We're going to start at the very beginning when the patient walks in the door. I am obviously going to take a very ED approach to this because I think in rural facilities that tends to be where most of our sepsis patients enter. Some of them may come from the clinic, but I think a lot of them walk through our ER doors or are brought in by EMS. So I'm going to kind of sequentially go through this as a patient would. So since I'm the first lecturer of the day, I'm going to start with a very basic definition. There's a lot of definitions of sepsis. I like this one though, because I think a lot of times when we think sepsis, we just go straight to infection. And there's a lot more to sepsis than just infection. So I really like that this definition talks about the overwhelming and life-threatening response. It's basically the body's ramping up to fight this infection so much that it's causing itself damage. So instead of just focusing on antibiotics, we also need to look at what else is happening with the body to truly treat this condition. So why is understanding and treating sepsis important? And I think in this crowd, I probably don't need to talk about this much, or you wouldn't be here if you didn't know the answer to this question. But some obvious statistics: it's very expensive, costs a lot of money to treat these patients. And more importantly, there's a really high mortality rate to this condition. So the better we manage it, the sooner we recognize it and treat it appropriately, the better the patient outcomes are. So first I'm going to focus on how these patients present for medical evaluation, because in all the reading I hear, a lot of the focus has been on you identify sepsis and how do you manage them. You know, you hear MAP, you hear central lines, you hear all of these treatments and assessments and monitors and tests that we don't have in a rural facility. What we have is an assessment, we have basic vital signs, we have basic tests, and we've got to make our decision and our treatment plan based on what we have available. So this is a slide that I really like from the CDC. I think it really summarizes the very vague symptoms that a lot of times sepsis patients have when they come in. They don't always come in with a week-long known infection and a fever and low blood pressure. That's not how they present to us. A lot of times we get very vague symptoms. Confusion, shortness of breath, high heart rate. These are things we see in a lot of patients that present for things other than sepsis. So I think one thing that should be a really key takeaway here is that we all work on developing screening tools in our facility to help identify these patients sooner. And these are objective measures. Now, I would love to say that there is a perfect measure out there that we all should be using in a rural facility to identify sepsis patients. But unfortunately, that's not the answer I can give you. There's a lot of studies going on right now to try to identify what the best way to identify these patients is. But I'm going to kind of go over some of the big three. They all have pluses, they all have minuses. Some aren't sensitive enough, some are too sensitive. But I think it's really important that we go back to our rural facilities and work on what works best for us. What resources do we have? What's our workflow in terms of how our patients come in and where we might capture these patients and identify some of these key features that may indicate the patient is at risk or has sepsis. So the first one I think most of us are familiar with because it's the one that's been around the longest, I believe, and that would be SIRS. That's the one that we tend to talk about a lot. And this is a very good one. There's studies that show that it does help. The thing I personally don't like about it is the white count is usually very, I have yet to see a patient who walks in the door and hands me their CBC results. It just doesn't happen. So I can't really evaluate these criteria for about, 45 minutes at least after they've arrived at our facility. So sometimes that really skews things. It does have value though. I don't mean to minimize it. It's just maybe not in a rural facility for screening those ER patients. The second one is QSOFA. This one, in my mind, it has the advantage of not requiring lab tests. It's something you can certainly do in your triage process to really assess those patients and say, hey, do I need to be thinking about sepsis? The third one, some European studies actually show this may be, early studies, so I don't say that this is the best, but some of the studies indicate this may be of benefit and be one of the strongest screening criteria for rural ERs. And you will see everything on there respiratory rate, oxygen levels, everything is something you're going to see right away. You're going to be able to assess right away when that patient walks in the door. And it can have some value if you've got a score greater than 5. Maybe you need to notify the provider. Maybe you need to be thinking about sepsis and maybe do a little bit more history taking in terms of recent infection or recent surgery or anything that may put this patient at risk. So once you have identified a patient at possibly having sepsis or being at risk of sepsis, or that's kind of in the back of your mind, then what's a basic sepsis workup? Now this is what the one I'm going to show you is by no means perfect. This is what we use in Crete. This is what I use, and I'll give you the reasons why I like it. It is not perfect, and it won't work for everybody because some people have tests that we don't have available to them, and some people don't have all the tests that we have on here. It includes just a basic workup. If someone walks in and I think they're at risk for sepsis, this is sort of my go-to. This is what I think through. And sometimes I don't order all the tests on here, but it at least helps my thought process in terms of evaluating, is this patient, would this be appropriate for this patient or not? The fluids are on here because if they walk in the door and they're screaming sepsis, which doesn't happen very often, but sometimes they do, I can go right to the appropriate treatment in terms of fluids, and then I have another resource to do the antibiotics. Whatever you decide to do and whatever route you decide, the easier you can make a sepsis workup for the providers, the more efficient you become, the more accurate you become, and the less likely you are to miss a key test. So whether it be on paper, whether it be a protocol, this is an order set for us, an order panel, but whatever you call it, the easier you can present that information to the provider who may be thinking about 100 other things at the time, the easier it is. So why is sepsis so challenging? We've got these high mortality rates. We know we can do better. What is it that makes sepsis so challenging? And there's a lot of reasons, but my personal concern is recognition. I'm going back to this slide. Now this is, I think many of you have seen septic patients that kind of come up and you're like, holy cow, they're septic? I had no idea. Because they present in a vague way. You see an 80-year-old who comes from a nursing home, oftentimes they can't give you a history of anything. Maybe you didn't get all the nursing home records and realize they were treated for a UTI a week ago. Maybe they can't tell you where their pain is or what's going on with them. So one of the problems we have is if you think about it from a provider standpoint and a nursing standpoint, when you see these patients, you're thinking about a lot of other potentially life-threatening and urgent situations that could present with these same situations, such as high heart rate, shortness of breath. I'm thinking anxiety. I'm thinking a lot of other things. Is it SVT? If you don't have a history of infection and something in the history to guide you down one trail, you've got a very broad realm of diagnoses you've got to consider. Clammy, sweaty skin, extreme pain, opioid withdrawal. Could it be illicit drug use causing the confusion and high heart rate? Could it be a PE? Another condition, I don't want to go down a sepsis trail and miss another critical condition. So this is what makes sepsis challenging, and this is why, and I have a few more here. Obviously, we don't want to miss an MI as well. This is what makes things very, very, very difficult. It takes time to rule out these other conditions, which is what makes a screening test right when these patients hit the door, some sort of objective measure, even more important, because it can really funnel you down that path a little bit sooner. So let's talk about the initial treatment of sepsis. You think this patient may have sepsis. They're giving you some signs, a little bit in the history. They make you a little nervous. This right here is basically the summary of my talk. I could probably stop now, and especially in a rural facility, because everything on here is something we are capable of doing. We can do all of this. We can recognize them. We can do screening tests as well as anybody. We can start antibiotics. And this goal-directed hemodynamic resuscitation is basically fluids and a vasopressor if we need it. So stay focused. It's so easy in a rural facility to be thinking about other patients and arranging a transfer and what do I need to chart and what does the provider need to take care of the patient. It's very easy to get distracted and be thinking about other things, but this really, if you're thinking sepsis, should be the very core thing we constantly go back to make sure we're not missing it. This next slide really hits home to me as to why we can really have an impact, why it matters, why we can't just say, yep, patient's septic, need to arrange transfer, yep, got transfer acceptance, let's move on to the next patient. We cannot do that because we have an impact, because those first few hours truly matter. This one really opened my eyes. I mean, obviously, like most conditions, the longer you wait, the worse the outcome. But I mean, this is a matter of hours. This is a few hours. This may be your 2-hour transport time to the tertiary facility. So we can't wait and hand it off to the tertiary care facility to do all the treatments, because we are capable of doing the right treatment right away. You wait, I mean, if this slide, if you wait a mere couple hours, you've dropped your survival fraction by almost 25%. That's immense. So we really need to be thinking about this and moving quickly. This is just another slide. Severe sepsis, I'm not going to get into the definitions. Denise back there knows all these, and Abby knows all of this far better than I do. There's a lot of discussion. You'll see I'm not defining a lot of terms because some of the guidelines are changing, which makes things confusing. They changed the definitions, they changed some of the treatments and recommendations. But at the core of this, sepsis is really a continuum. And to me, in a rural facility, you have two types. You've got early sepsis, where you can treat with antibiotics and maybe just some basic, maintenance fluids or a liter over an hour. And then you've got severe sepsis, where you really need to ramp up. Because your treatments in a rural facility, we're a lot more restrictive. We're a lot more limited. So we either need to really move on this patient, or we need to move on this patient, but we may be able to consider keeping them here. Either way, you can see the sooner you act, the difference in mortality is immense. So the key is to identify and move fast on treatment. So this is the easy part. You identify sepsis, how are we going to treat it? Very basic. Antibiotics, broad spectrum or best. I'm not going to delve into the antibiotic choices because Kevin, the speaker who's up next, knows more about antibiotic treatment than I could ever dream of. So I will defer to him. But the key is usually going to be to treat with 2 broad spectrum antibiotics right away. Get things started. If you can identify the source, then give a source directed treatment. Secondly, fluids. Now, a lot of the reading I read regarding sepsis really focuses on this 30 milligram per kilo bolus, which is very appropriate if your patient is starting to become hypotensive. But what do you do for these patients that present with very early sepsis, and maybe they've got a history of renal failure and heart failure, and they're not showing any signs of hypotension? Do you really want to flood them with a bolus? There's some studies that show that may cause harm. So it's very important that we really look at this patient and we say, are they heading down the path of bad sepsis? We've got hypotension, they're starting to go downhill. Those are the patients you give the 30 mil per kilo bolus. But if it's someone who you say, yep, they've got an infection, I think it's early, but it may be early sepsis, it is appropriate to give a 1 liter bolus over an hour. That's okay if you're not seeing signs of hypotension. So it's very important that you really recognize that, because I'll say in my reading, I sometimes get so caught up in this 30 mil per kilo bolus that you forget if you catch them early, that may not be a benefit. That may actually be a detriment to some patients. Third, monitor the patient closely. I will admit, and I think we have some nurses over here that has probably seen me do it. Once you get acceptance, it's very easy to move on to the next patient and not necessarily consider monitoring the patient that's received acceptance. And I know I've seen it in other facilities too, where, okay, good, got to get the paperwork together, we got acceptance. Okay, the patient's fine, we got antibiotics treated, go in, they're fine. But these are patients you really have to monitor closely. Every 15 minutes, you need to reassess them. What's their alertness level? Are they declining? Because if they are, there are things we can still do before transfer to head this movement from early sepsis off to bad sepsis. We can start vasopressors. We can do other things. Do they need oxygen? Are they starting to decline? We really need to watch these patients closely and not just sort of write them off and say, tuck them in, they're comfortable, we're just waiting for the ambulance. Monitoring these patients closely really does matter. Sometimes they will surprise you and turn quickly. And the next thing would be, if you're starting to head toward bad sepsis, and you may, especially if you have a long transport time and you're noticing that they're having increasing oxygen needs, maybe pneumonia is the source infection, do you need to intubate? Do you need pressors? That 30 milligram per kilo bolus is not doing it. Maybe we need to move on to pressors. Those are things to also consider. So this is really the core assessment to me in a rural facility, because we're probably not going to put in an ART line. We probably don't have a central line. We probably don't have a lot of the resources that other facilities do, but we can do this, and we can do this well, and we can do it quickly. Another thing that can really aid a patient with sepsis is to really debate early whether you're going to transfer them or not. Transfer can be kind of a tedious process, and I'll describe that a bit. Many of you will have lived this, so I probably am not going to tell you anything you don't know. But sometimes protocols can be very helpful at your facility. The decision as to whether to transfer a patient or not can sometimes be difficult for nursing and providers. Are they going to turn? Are they going to go downhill, or is this something we can manage here? That's a tough question in some patients to really ask. So a lot of places have started to develop triggers or things to identify whether this patient is able to be handled in your facility or not. Some of them include what's the lactate level, what's the blood pressure, is there signs of organ dysfunction, is it just one or is it two or more? We're treating them, but they're still not getting better, and the fluid bolus had no effect. Now you'll notice on this list of criteria, I did not put actual numbers. And the reason I didn't is every facility is different. I can't tell you whether you have an ICU or progressive or whether you can manage some of these patients or not. But this maybe should be something you take back to your organization and you decide, is this something we're capable of handling? Can we handle someone that's starting to turn down? What are our resources that we can provide this patient? Can we justify keeping them, or is this the point where we really need to consider transferring? And who and when do you call? Sometimes who you call, when you call, whether they have bed acceptance, whether you have a transport, those are all very sometimes tedious processes. So if you have a standard process, if you always transfer to one facility, that makes things a lot simpler. But some people are not in the situation where they have that opportunity. But if you have a facility you like to transfer to, that is very competent to handle sepsis care, then maybe work with them on having a standard process, an acceptance agreement. There's a lot of things that can be done to make this process more standardized. This is a slide. I really don't want you to focus on rural versus urban here. It really is just to emphasize that when you have a patient who may be heading downhill, experience matters. You can see at the bottom of this slide, the facilities that handle 500 or more sepsis patients tend to have the lowest mortality rate, which is pretty intuitive. If you manage it a lot, you manage it well, you're probably going to have a little bit better outcomes. But it's sort of something to consider when you have those patients that are starting to turn the corner, and you may have someone who's really thinking, oh, we can take care of them here. You need to question, can we? Can we take care of them here? If they start going downhill a little bit, can we handle this? Do we have more resources if they start getting worse? And it just kind of made, it was a little surprising to me to see this much of a difference in mortality between the low volume facilities and high volume facilities, but it does matter. So if it's not something you think you're capable of taking care of, please move on to transferring to a larger facility that has more experience with it. But then on the other end of things, as many of you know, the transfer process itself can cause harm to the patient and does have a lot of risks involved. So it's very careful that we weigh both of these decisions, and we have, like I said earlier, perhaps some criteria for when we transfer and when we don't, because this can become a very muddy process. Many of you that have transferred patients, you realize you can have a patient decline in transfer. Maybe the transport service you have doesn't have the resources. They don't have the tools you need to take care of the patient, so you have to get a different level of care. There can be delays in that care, whether it be a delay in transport, whether it be weather, whether it be the ambulance crew isn't available. There's all kinds of things that can go wrong in a transfer. There can be accidents. The other thing that can happen is anytime you have a patient care handoff, you're at risk for missing information. And Dr. Clough is going to be one of the lecturers later on to kind of talk about her end on the receiving facility and how important it is they get the information. But I think all of us are aware, whether it be nursing report or physician-to-physician report, it's very easy if you get going to miss some key piece of information. And every time we do a patient handoff, you have an increased risk of patient decline. The other thing I really want to mention is the neglected patient preferences. Oftentimes, especially in rural facilities, we have these patients, if they come in and they're do not resuscitate and they're do not intubate and their entire family is around and maybe they don't think they have much quality of life, that may be a factor to consider when you're debating whether to transfer them or not. We've kept some patients in our facility where had they been 20 years younger, not had comorbid conditions, and lived at home, I absolutely would have been pushing to transfer. But if they're a no-code and they've lived a good life and they say, I'm comfortable with just being admitted here and we'll see what happens, do what you can, but I like having my family here. I like having them here every day. If I'm transferred 2 hours away, I won't have anyone there for me. Those are things to think about too. And sometimes we get caught up in this whole, they have sepsis, I got to get them out of here. We neglect the patient. So again, with those certain patients, make sure you think about that and talk to family and take those considerations into account when you're making a transfer decision. This is just an example. I'm sure many of you from rural facilities have a very similar process, and it won't be new to you, but those at larger facilities, I want you to think about how much of a burden and how much of a time time sucker, I guess it takes to transfer a patient in terms of all the steps that are involved. And these are sequential steps. It's tough to skip around. And any of you who have been involved in a transfer from a rural facility know what this is like. And I guess I don't need to tell you, just happens to be what we do in Crete. But it is something to consider when you are doing all of these steps. Number one, at a rural facility, don't forget to monitor the patient. These can be consuming, taking the phone calls, getting acceptance. You may be taking another patient in the ER. You monitor the patient. Don't forget the patient while you're doing all of this. And for those of you at larger facilities, please don't forget when there is a delay, we have a lot of steps, and some of these are out of our hands, and we cannot control some of these when we get bed acceptance, when the ambulance arrives. There's a lot of things that need to happen in that process. So if you've decided to transfer, you've done your workup, you've diagnosed them with sepsis, you have acceptance, these are there's obviously patient-specific things you may need to consider for every case, but these are 4 key things that really you shouldn't miss. You really should have a checklist. If you're transferring someone with sepsis diagnosis, if you can get a lactate level, make sure you got it. It may not help what you're doing here at your facility before you transfer, but it really may have an impact on that patient down the road in monitoring those levels. 4 hours later, has there been a change in lactate? Has it gone up? Has it gone down? That can really have a value. And if you're waiting half an hour for the ambulance to arrive, that may be something you want to consider. Obviously, if you're going to start antibiotics, you need blood cultures first. Administer those antibiotics like we talked about earlier, and also make sure you've got the fluids running, whether it be the bolus if they're hypotensive, or whether it just be a 1 liter bolus if they seem to be very stable. So how are we different in rural areas? How is sepsis care a little bit different? We have some challenges that some larger facilities don't have. We're often very limited in staffing. Like I mentioned, a lot of times it's the same nurse monitoring the patient, checking in another ER patient, taking the acceptance phone call, and then having to call nurse report. And sometimes that's a lot for one nurse to handle. So I think the more we can move towards treating sepsis, like we do STEMIs, like we do strokes, like we do traumas, where it's sort of, okay, time to ramp up the team and everyone help out, I think the better care we can provide. A lot of times we don't have the antibiotics. Certain antibiotics are not available. They're not on formulary. They're not used very often. We don't have them available. Blood products may not be available if a patient is really in severe sepsis, septic shock. We may not have testing available, whether it be just not available at all, or maybe your machine is down. Again, I covered transfers, but that is a challenge that a lot of larger facilities don't have to face. And we also have some challenges in terms of staffing. There's very few places rural that I know that aren't constantly having to get either locum tenens providers or traveling nurses sometimes to fill gaps. Whenever you have that transition and you've got different people filling in, they may not know your process, they may not know your protocol. It may take them longer to get bed acceptance, they don't know who to call. So the more we can standardize and have workflows that really guide people to do the right thing, the better. Because some of these challenges we really are going to be facing for a long time, and we can't make them go away. This is a slide that was kind of another one like the mortality slide that really I don't want you to interpret as doom and gloom. The gray bars there that you see are patients that are transferred usually from a smaller, more rural facility. The black bars are patients that are admitted directly, from the ED to a tertiary care facility. And no surprise, the black bars are just a little bit better. But I think, the lesson to be learned from this is the things that they're better at, there's really no reason for it. There's really no reason. We can't be doing blood cultures and making sure we get it. That we can't be given those fluids right away. And that we can't be measuring a lactate. These 3 bars over on the far right, are the ones that I think we can really improve on. We're giving antibiotics, the antibiotic rate I think we're doing okay at. Are we giving the correct antibiotics? Maybe not, but I will say sometimes it's very hard in a rural facility to do all the tests needed to identify that source infection. The key is, again, start the broad spectrum if you can't identify the source, and get them started as quickly as possible, as soon as you're thinking sepsis. So, if our resources are limited, why don't we develop a sepsis system in rural facilities to arrange direct transport to a larger facility like we do traumas and STEMIs? This has been shown to be a major benefit in the trauma world. STEMIs have shown benefit. We've even seen some with strokes where you bypass you have EMS bypass them. If they're sick, get them where they need to go for definitive care. But ironically, sepsis is very unique. Sepsis patient identification is much tougher than those other three. You know, a trauma, yeah, you can see the car accident. You can see a deformed bone. A STEMI, you can see those tombstones on that EKG. It's usually much more clear cut. Something that can be easily identified in the field. You can have strict criteria and you can get them transported where they need to go. We've already talked about how sneaky sepsis can come in. They can come in with very vague symptoms. It's not easy to identify. So having EMS identify them and take them to a larger facility is not very feasible. Secondly, unlike the other critical conditions, a STEMI may need a cath lab. Trauma probably needs to go to surgery to stop the bleeding. We have the resources at our facility to take care of these patients. We have antibiotics. We have fluids. We can do this. There's no reason we can't start that initial treatment at our facility. And third, there's some evidence that patients who bypass with sepsis have poorer outcomes. This person that I cited, this Nicholas Moore, I don't know if any of you are interested in reading more of this. He's a physician out of the University of Iowa who's done a lot of research on rural sepsis, and he's got some really interesting studies that are trying to find better ways to provide care to sepsis patients in rural areas. And one of his studies was about this bypass, and it was surprising that patients who bypassed, and these were mostly private vehicle patients who bypassed in a private vehicle, but the same could be true if you're considering an EMS system as well. Patients who bypass have a higher mortality rate. They just don't do as well. So, it does show that we make a difference in rural facilities. It's just, I think we can all work to improve and maybe do a little bit better. We want to make sure we don't miss some of those patients that we maybe don't do all of the protocol. We just start it and we stop it. So I think it's really important that we recognize that we do matter and we can have a significant impact on these patients when they come in. So these are, I guess, my key takeaways here in terms of how to improve care. First of all, the standard screening process, whatever it may be, SIRS, QSOFA, NEWS, so that you can identify these patients sooner. Always keep sepsis in the differential diagnosis. Like I mentioned, we think about STEMIs, we think about MIs, we think about strokes, we really think about those, but I'll have to admit I'm guilty of it. Sepsis was probably lower down. I wouldn't think about it unless it was staring me in the face. And I think as more education comes out to the public as well as to us, and more of us attend conferences like this, I think we need to move it up. We need to move it up in our mind and be thinking about sepsis sooner. Have a standard workup, order set, protocol, workflow for the workup for these patients as well as treatment. Treat with antibiotics and fluids promptly. Consider transfer early and carefully, and then make sure that appropriate treatment can continue during transfer. I'm not going to talk about this much because that's the focus of Dan Duncan's lecture next. And for more information, this was a webinar series that I found that they do focus on that Nicholas Moore. For any of you in a rural facility, this was a really valuable website. There were several webinars that I found of a lot of value. It's focused not just on tertiary care sepsis, it's focused on rural sepsis. And this was a really good resource. And I got a lot of good information out of it. So for those of you who are interested, please check that site out. And next, I'm going to move on to transport of septic shock patient with Dan Duncan. Dan is sort of, I know Abby introduced him, but he truly is a guru of EMS medicine in the state. And he knows more about vasopressors than I probably ever want to know. So I'm going to hand it over to him to talk a little bit more.
Well, thanks. So picking up where Dr. Verton kind of left off, she did a great job of explaining some of the challenges in the rural setting. And so just so we kind of have an idea in the audience, how many people in the audience here work at like one of the major hospitals here in Lincoln, and that's where you've pretty much worked your entire nursing career if you're a nurse? Yeah, so some of this may actually become somewhat shocking to you when we talk about some of the resources that aren't available out in some of these rural areas. How many people work at a hospital now with probably a population of less than 5,000 people in their town? Yeah, so those are the ones that I get to see a lot of. And I tell you, until we moved down to Crete about 6 years ago with the helicopter, I really didn't have as good an appreciation for what they do out there in some of these rural hospitals than I do now, because we got kind of spoiled. We were based out of here. We're based out of a large hospital. We fly down. We kind of look at what's going on and go, God, what are they thinking? But now, being at the Creed Hospital and being part of a lot of these sick patients from the beginning, I learned a new appreciation for what it is they have to deal with and some of the challenges they have just to get that patient transferred to one of the Lincoln or Omaha or Kearney hospitals, whatever hospital you're transferring them to. And so I'm just going to talk about the transport of the septic shock patient and some of the challenges that for the most part, a lot of our critical access or smaller type hospitals have when dealing with these types of patients, okay? And so to break it down, in the state of Nebraska, we basically have, we really have two levels, basic life support and advanced life support. And this is basically the type of transport program that's going to be taking these patients to the hospital that you're wanting them to go to. So when we talk about a basic life support, those are going to be your EMT level, first responder level ambulances, okay? So in the state of Nebraska, in order to transport patients by ambulance, you have to have at least a minimum of an EMT basic in the ambulance. You can be trained at the first responder level, but first responders typically don't transport patients. They can take care of patients until the BLS folks get there, but they're not allowed to actually transport patients to hospitals. So what is a BLS transport service like? What are they able to do, and why does that affect the decision on what we're going to do as far as what type of level are we going to use to transport these patients to a higher level of care? So your EMT levels, first of all, we have to understand the difference between paid and volunteer. So the folks that live out in the rural settings, they don't have paid people just sitting around waiting for the call to come take care of these patients for them. So they may or may not get anybody to respond. And so that's something that's the first challenge is, are we even going to be able to get anybody to answer the page, if you will? They page out a volunteer and nobody shows up. Now, they're not required to show up. They're working. They have full-time jobs, and on their time off, if they're available, they respond to the page and they go get the ambulance and they come pick up the patient. But that doesn't always work that way. So that's some of the bigger challenges that we face in a lot of our smaller hospitals. I use like Friend or Henderson or some of these small hospitals that they just don't have a lot of options. You get into the Yorks and Fairburys and some of those size hospitals, and they do have paid either ALS or BLS people that can respond, but they're limited on some of the equipment and training they have, and so we'll talk about those as well. So what do you need as far as what level? And so we have advanced life support or ALS, and so typically what an ALS transport service is capable of doing is they have at minimum one paramedic on board. And so that's what constitutes advanced life support. So what are these paramedics able to do, and how does that help our patient that's needing to be transported into a higher level of care? So they have your basic IV skills. They can usually intubate. They carry, your ACLS level drugs. But a typical advanced life support service is typically a resuscitation unit for the cardiac arrest, the trauma resuscitation. But they're not typically going to carry a lot of the drugs that are going to be needed to resuscitate the septic shock patient. That's when we're going to get into a little bit higher level of care or get into the critical care world. But unfortunately, right now, we're working on it in the state of Nebraska. They don't recognize critical care as an actual level. It's gone through 3 committees, and it's passed all 3 committees as of, I think, this week. And so we'll create some legislation and send it up to the governor's office, and hopefully within a year or two, we'll have identified critical care as a separate 3rd level. And the why that's important is because critical care, whether it's ground or air, we assume that when they show up by helicopter, they're going to have all this equipment. And that's a pretty safe assumption. However, there's no regulation in the state of Nebraska that that's the case right now. This would help both the ground and the air medical world be more consistent on the training and the equipment that are being carried on either an ambulance, airplane, or fixed wing, rotor wing helicopter, whatever the mode of transport is. So critical care ground, if it's a true critical care ground, they're going to carry most of the equipment that you would have on the aircraft or the helicopter, but it's just coming by ground, whether it's because air is not available or they just decided that the patient doesn't quite meet the criteria for air medical transport, but they're certainly sick enough that we need a critical care unit here, such as the pressors, antibiotics, and maybe even some advanced airway management. So Dr. Burton did a really good job of talking about some of these things that the patient may need prior to transport. But how many folks in this room do not have the luxury of having an in-house pharmacist 24/7? Yeah. So when you need that Levo drip or that Epi drip, who mixes that? You do, right? Okay. Some of the Lincoln nurses, when's the last time you mixed your own Levo drip? Ever? Yeah, probably not, right? So that's one consideration that you have to think about. And how many have in-house anesthesia or don't have in-house anesthesia 24/7? Yeah, same ones that don't have Levo or pharmacies. And so intubation, as it sounds simple when you're on the other end of the transport going, hey, we need you to just intubate the patient and send them our way. How hard can it be, right? Just get them intubated, get the antibiotics. If they need Levo or they need a pressor, start a pressor and get them here. Well, it's not that simple. Our mid-levels and physicians certainly can intubate, and some of our paramedics are competent enough to intubate, but it's just not always that simple. Okay, not everybody is just very easy to intubate. And even if we do get them intubated, now what do we do with them? Are we going to ventilate these patients 2 hours with a bag valve mask? Or are we going to put them on a ventilator, which is the best practice for this patient? And if we're going to put them on a ventilator, does the BLS squad have a ventilator? No. Does the ALS squad have a ventilator? No. Does the critical care? Yes. But how long is that going to take them to get here from Lincoln, Omaha, Kearney, wherever they're coming from? And then if that's not the option, that's where the air medical transport comes in, the critical care air medical, whether it's via helicopter or fixed wing. So the point being, I just wanted to kind of break down the different levels of care in the state of Nebraska currently and why that matters in the transport of the septic shock patient. And so usually when we're initiating these antibiotics and or pressors, we need them to be on some sort of infusion pump, right? We probably wouldn't want a free flow Levofed 2 hours down the road, I hope, right? Nobody would probably consider that to be a good idea. Well, does the ALS service in your community have an infusion pump? Probably not. So what's your hospital's policy on sending an infusion pump out the door with a paramedic that has no idea how to run it? No idea how to fix in the paramedic world, I'm guilty as charged. The first button we hit is silence because we don't know what's wrong, so we just continue to hit silence. Well, if we're hitting silence, it's safe to say that Levofed drip's no longer infusing. And after this paramedic that was just handed an infusion pump that he's never seen before or troubleshot is now trying to fix it going down the road. And so you've got to ask yourself from a liability standpoint, what would your hospital's policy be if something bad happened to that patient during transport and it's your hospital's equipment that failed? Is the liability on the provider that was never trained, or is the liability on the hospital that said, hey, just take our equipment? It's all good. You'll bring it back, right? And good luck, by the way. And so we see a lot of that, unfortunately, because it's all they can really deal with. That's all they really have as an option because they don't have other resources available. And so just something to keep in mind when we look at what's the best mode of transport for these patients. Fluid therapy. Dr. Verton talked about the criteria, the 30 mils per kilo. And one thing I would just add to that, and I really don't want to get too deep in the woods, but 30 mils per kilo is certainly the guideline, but they're really starting to look at 30 mils per kilo of ideal body weight. I don't really want to blow anyone's mind here, but yeah, we unfortunately have to have math involved with that. And so cheat sheets come in really handy. But if you're not familiar with ideal body weight, it's really big in the respiratory world because when we put patients on a ventilator, we're basically calculating their tidal volumes off ideal body weight, not total body weight. And that's significantly different. Somebody that weighs 300 pounds and is 5'2" has an ideal body weight of 60 kilos. And if we did the math of total body weight, we'd be looking at about 170 kilos. And that's a big difference in your tidal volumes that you're delivering. And it's also a big difference in the amount of fluid. So you're probably not wrong by just doing mLs per kilo of total body weight, but to be more specific so we don't overload those patients with fluid that are right there on the borderline, calculating that off of ideal body weight is sometimes your better option. But if they're on a pump, once again, and you need them to be at a certain rate, does that transport service that's coming to get your septic shock patient have that equipment available to adequately do that? The intubated patient, if they're super sick, their lactic acid is really high, their pH is really low, they're tired, they're fatigued, and we do need to go ahead and intubate this patient. Can we get them intubated? And once we do get them intubated, how are we going to get this patient safely into a higher level of care? And bag valve mask ventilation, although, we think we're good at it, we're terrible at it. The only people that are really good at bagging patients are anesthesiologists and CRNAs because they do it for a living. But we're really bad. We do a decent job for a little while, but it's like CPR compressions. We slowly start to get kind of lazy and our compressions aren't as deep and they're not as fast. And then we try to play catch up with a bag valve mask. We'll set it down for a second. We'll do something, we'll answer the phone, we'll check our text, and then we bag 4 more times real quick to make up for that 4 seconds or 5 seconds that I check my phone or whatever. And that's not good for your patient. These patients require adequate tidal volumes, adequate minute volumes, and they need to have specific parameters, especially when we're dealing with patients that are septic with low pHs. We want to help improve that low pH by increasing their minute volumes. These patients need higher minute volumes than they normally would if they weren't septic. So we can put them on a ventilator, we can turn on the ventilator to a specific rate and a specific volume, and we can monitor those parameters in the critical care air medical transport arena and then the critical care ground if they have the ventilator available. I really doubt, and I hope nobody's sending ventilators out of their hospital in ALS ground units. I hope not. That would not go well if something happened en route to the hospital with the hospital's ventilator, especially if they weren't trained on it adequately. And that's a challenge with the critical care ground units is unless it's a high volume, service, we just don't have enough volume to adequately train the paramedics on how to run a ventilator adequately. And so in the critical care air world, we tend to see a lot of intubated patients. We have a lot more training on the ventilators. We work with the respiratory therapies departments at a lot of the bigger hospitals to maintain our level of competency on these ventilators. So we're pretty comfortable using them and diagnosing and treating patients on the ventilator. But a lot of our critical care ground folks, unless they're in a high volume service, may not have all that experience. Pressors. I'll talk a little bit about pressors. I'm certainly no expert like Dr. Verton alluded to, but I think you'll be surprised when we talk about some of the pressors, especially for some of the nurses in this room that have been doing this a long time. There's a certain medication that kind of comes and goes with the time and it's back again, and that's Levophed. We used to have that saying, Levophed, leave them dead. Well, that's not, it's sometimes the case, but hopefully not. But the drug has come back again. It's usually the first line, pressor in sepsis. So we'll talk a little bit about that. And then just reiterating on the equipment availability, just understanding that ALS is not critical care. Critical care ground may not be as equal to critical care air. In a perfect world, they both have the same exact types of equipment, but one's just faster than the other. And that's what your air medical would provide versus a critical care ground. But if you're not sure, if your fire department is who does your transport, and you're curious as to what their capabilities are, reach out to their fire chief and say, hey, can you come out to the hospital and just kind of give us a lecture on what it is you're capable of doing. And you may be surprised that, even though they're paramedics and they're really good providers, it's those long transports where they may be in a little bit over their head because they just don't used to taking those sick patients for long periods of time. I worked here in Lincoln for 15 years in the streets, and I had that luxury of being 5 minutes away from a hospital. Worst case scenario, drive fast. Get him to the hospital. I don't know what's wrong with you, but I know there's a hospital over here on the corner, and they will find out what's wrong with you. And so it's a lot different, from the pre-hospital standpoint, when all you really need to do is get him to the hospital alive. Now my job is to get them from a hospital that might be 90 to 150 miles away from the hospital they need to be at, and do that as safely, effectively, and efficiently as possible, and provide the highest level of care. So these are just some of the equipment requirements for critical care transport of the septic shock patient. So you'll see on the which is my left, that's our ventilator, our critical care transport ventilator. Very small, very lightweight. In the air medical industry, everything needs to be somewhat weight limited. And so we have these tiny little IV pumps like the one you see in the middle picture up underneath that radio there. That's a 2-chamber IV pump. Cute little pump, isn't it? Nice little tiny thing, fits in your hand. But unfortunately, because it's so small and tiny, we leave it behind a lot because we forget it. But we have like 4 of them in the helicopter in case we do so. But those are our infusion pumps. Our ventilator, it's able to do most of all the modes that our ICUs want us to bring these patients in on, APRV, PRVC, whatever, all these modes that the critical care docs want us to transport them on. We can use our ventilator for those modes. And of course our monitor. We can do 12 leads, we can do art lines, we can do core temperatures. So if we want to monitor their core temp, we have the ability to do that. Up to 2 art lines, up to 2 temperatures. So the monitor itself is a high level piece of equipment, and we can monitor a lot of these super sick patients in flight. Okay. So just talking a little bit about vasopressors, assuming that the fluids aren't working, we need to go to another, a plan B, if you will. And I know the slide's kind of busy, but at the end of the day, don't be afraid to get into the pressor world. Don't continue to load them up with fluid. If fluid's not working after that 30 or maybe 60 per kilo bolus, it's probably not the problem. There's certain types of shock that they may require more fluid than others, but we need to start being concerned if that fluid bolus isn't working, especially if we've already got that patient and we're already behind the curve a little bit. So when they got to the hospital, they were already in that mild to moderate shock stage. I see 2 types of patients, or I go after 2 types of patients. The patients that are coming out of hospitals that know this patient doesn't belong here. Right away when they walked in, we're going to do our best, but they are not staying here. And then I go to hospitals that I think we can hang on to them. I think we can fix them. 2 days later, we need your help. We're in trouble. We're wrong. Patient's super sick. They're already on levo. They're already on vasopressin, and it's not working. Now it's our job to get them to Lincoln where they can fix them and take care of what's causing the septic shock. So 2 totally different scenarios. I tell you, I have a great deal of appreciation for the first scenario where we go in and they know, hey, thanks for coming, man. We knew this patient was sick. We got you coming right away. We've done the best we can. We got 1 good IV. We've given 30 per kilo. Okay, do you have any antibiotics? No. Well, we do, but we haven't started any yet. Okay, let's get some antibiotics going. We carry antibiotics on the helicopter. We can carry blood on the helicopter. So we have a lot of those things that Dr. Verton talked about that may not be available at some of these smaller hospitals. We bring that with us. And then, of course, we obviously carry all the different pressors that we may need. So first line agent usually are the first pressor that we're going to probably go to in your septic shock patient. Like I mentioned, is your Levofed. And so Nori-Epi. Whether it's weight-based or mics per minute, it doesn't really matter. The benefit to using a weight-based calculation is you can get up to some of the higher doses. Meaning if you're simply doing the 2 to 10 or 2 to 20, it doesn't take long to get up to 20 mics a minute of Levofed, and it's not working. But if you did the math and went to a weight-based, you could be up to 50 or 60 mics per kilo a minute, or what would be equivalent to 50 or 60 mics a minute of levo with no problem whatsoever. So we prefer to go weight-based with all of our pressors because it allows us to get up to higher doses without being, feeling like we're maxed out sooner than we should be. But remember, 1 pressor may not always be enough. It may be a combination of a couple different pressors that are going to be needed. But usually Levofed's your go-to, and then Epi is going to be your probably number 2. Along with levo. So the 2 of them are probably going to be used together. So if we're using Epi, they may be bradycardic, and so the Epi may help with that. But we typically don't go with our dopamine like we used to. I mean, dopamine has been around a long time, but it's got some good uses, but not in the septic shock world. Remember, it's an inotrope, so it's a contractility drug. So those are going to be more beneficial on your patients that need some squeeze of their ventricle. They've got a pump problem. It's not a vasodilatation problem or a sepsis problem. And so your dopamines usually aren't going to be the drug of choice there. But we do see a lot of dopamine being used because it's an old school drug, and we know we're used to it, we're kind of comfortable with it, and we know it fixes blood pressure, right? That's what dopamine does, it fixes blood pressure. So start some dopamine. It does, but it's not the best pressor available for these patients. So don't be afraid to get that Levofed out. And, like I said, if you're not used to infusing, any of these pressors, just take your time when you're mixing these medications. And so we're not giving the patient, quad strength or double strength, infusions. And what I mean by that is, if we mix 8 milligrams and 250 instead of 4 milligrams and 250 of Levophed or Epi, and we don't set our pump up that way, we're actually giving them either half as much as they need or twice as much as they need. So the first thing I do when I get to the bedside of a patient that's on a pressor is I verify that what in fact is on the bag or labeled on the bag matches what is on the infusion pump. And you'd be surprised how many times I've caught a medication error that, it's usually, they're either given twice as much or half as much because the person that mixed the bag and the person that punched them numbers into the drug calculator on your infusion pump weren't on the same page. So just be careful when you're doing that. Just another busy slide here, but it just talks about dopamine, and then at the very bottom is Neo. We use Neo in the aeromedical world as a push dose pressor. And so what we do there is these patients that are super sick and they need to be intubated, they're to the point where we need to intubate them, but they're hypotensive, and we're worried that if we take away any of their sympathetic drive by paralyzing them and intubating them, they're just going to check out on us. They're going to give up, they're going to go into PEA, and we're resuscitating them. And so Neo is a good drug as a push dose pressor. So we'll mix up a cocktail of Neo, and we'll give little bumps of Neo to get their pressure up high enough to where we feel it's now safe enough to go ahead and RSI that patient and get them intubated and put them on the ventilator. And then we can give a little bit of that Neo until we can get the infusion, but it's bridge to infusion. We don't want to continue giving bumps of Neo or bumps of Epi or vasopressin during transport. Ultimately, we want to get the infusion going because that's always going to be a better option. We can titrate it much better than we can a Neo bump. So this is just a diagram basically showing the different pressors and some of the dosing. Like I said, the ICU typically does everything and weight-based, but don't be discouraged or don't be upset if you call in a report to one of the Lincoln hospitals and you say they're on 10 mics of Levophed. And what you mean by that, it's 10 mics a minute. And they're like giving you what do you mean 10? They have no idea what that means because they're not used to doing Levophed at mics a minute. They're used to doing it in mics per kilo a minute. Don't worry about it. Just say, hey, it's 10 mics. They can figure it out. If they know the weight, they can do the backwards math and figure out, well, 10 mics a minute for a 70-kilo patient would be equivalent to 0.15 mics per kilo a minute or whatever. So don't worry about that too much. Do what you have to do what you're comfortable with, and get these patients transported to a higher level of care as soon as possible. And that's going to be the biggest, challenge that you may face out there. So I just want to reiterate that, the importance of getting them, to the facility that they ultimately need to be at as soon as possible, and how that for the folks that are receiving the hospital patients in this room, the ones that are, the ones that are going to be accepting the patients in the ICU, keep some of these things in mind when you're wondering what's taking so long. Why did they do this or why didn't they do this? They're doing the best they can with the resources that they have available to them at these tiny little communities and these small critical access hospitals. It's not as simple as it sounds just to transport these patients and get them here as quickly as possible. And days like today, and in the next few days, it even complicates it even more. In Nebraska winters, we know, God knows what mode of transport you're going to be able to get any given day in the state of Nebraska, just because of weather. So keep that in mind when we're setting up transport on these patients. Any questions at all that you may have for myself or Dr. Verton on the treatment and transport of the septic shock patient in the pre-hospital world? Well, I appreciate you guys coming out and spending the morning here, and hopefully you enjoy the rest of your day. Thank you.